So first of all, welcome everyone. Thanks for joining us for our Burrows Consulting, Developing and Maintaining Your Sliding Fee Discount Program webinar. I'm really excited to introduce our presenter today, Christine Julian. Chris is a consultant with over 25 years of experience working along federally qualified health centers and community health centers across the country. She specializes in operational site visits, financial recovery strategies, and compliance with HRSA requirements. Her work often focuses on helping health centers optimize their sliding fee programs to ensure affordability for patients while maintaining the financial health of the organization. So Chris brings both practical insights and real-world solutions, making her a valuable resource for today's training. And we are very fortunate to have her with us. So let's give Chris a warm welcome.
Thank you, Kate. I really appreciate that. I'm excited to be here today to talk to you about this very important subject. It's one of my favorite things to talk about with community health centers, and I'm glad to be here to share all this information with you. Okay. The first thing I wanted to talk about just briefly here is why do we have to have a sliding fee program and as we're going along. So the purpose of the sliding fee is to ensure access to care. Patients, it kind of removes the financial barriers that patients have so that every patient, regardless of their ability to pay, can access essential healthcare services, which in turn helps the whole community in terms of staying healthy. It's also in statute, a U.S. statute, and is guided by HRSA in terms of making sure that we follow the rules that Congress has laid out for us in terms of making sure that we have all these important pieces in place. And also there are certain compliance expectations that go along with that, all of which is outlined for us in the Health Center Compliance Manual, which I will have a link for at the end of this presentation for you. The first thing I want to talk about is who can apply. And this is really the very simple question is everyone can apply for the sliding fee program. Then while I say that, not everyone's going to qualify for the sliding fee, right? Because they have to meet certain income and family size requirements to be able to see where they're going to fall. But anyone that walks through your doors can apply to be on the sliding fee. That in mind, it just makes sure that we are providing good care for everybody. The program is really focused on patients with incomes at 200% of below poverty, but you want to make sure that everyone can apply. Also, one of the most important things that's utilized in this program is the federal poverty guidelines. This is updated every year. It was updated just this last month in January, and it's usually updated in January. In fact, in the last 10 years, only one time was it ever updated in February. So it's important, if you haven't found that yet, that you update your sliding fee program in terms of your federal poverty guidelines. It's updated because of current economic conditions that Congress and the government has determined needed to make sure that we stay in the right, in terms of making sure that people that can't afford it can be able to in the right spots. Now, there are two things that's important in your policies that you have to define as a health center, and the first one is defining family size. This is a very important one, and a lot of people have different ways that they do this. Usually, when you think about a family or a household size, you're thinking, the family members of parents, children, that sort of stuff. But also you want to think about your population. If you have a population which has a lot of extended family, do you want to include those as your household members or not? You want to make sure that you would think about also adoption, extended families, people that are taking care of other members. So you get to decide who that is in your family. So it's important to think about your population, what makes sense for your population. HRSA allows you to make that determination. So it's really important that you think about who really belongs in that family. The second thing that they ask you to define is in your policy is what's income, all right? Income, it can be defined many different ways, but really if you get down to the basics of income, it's defined as a form of compensation or benefit received from work, right? So usually people include things such as wages, self-employment, Social Security, child support. and other type of regular earnings like that. But what thing is not included in income is actually assets, okay? So things like, your home equity, your savings accounts, as well as a specially targeted support systems that may be out there, such as food stamps or SNAP programs, any housing benefits, things like that are not included in that income. So you want to basically distinguish those two to measure financial need accurately. Now, in terms of the structure of the sliding fee, it's set up in such a way that you're looking at different fee schedule or different income levels and making sure that you kind of break them down. The structure kind of guarantees some consistency and fairness in terms of how the discounts are applied. And I think the next slide will tell us a little bit more, will show us a little bit more on that in a minute. In terms of definitions of nominal charge, the nominal charge is a fee that is charged for patients at 100% or below poverty. And that nominal charge represents the minimal fee assessed to patients, which should be low enough to avoid deteriorating them from seeking care while still covering some basic costs, right? Because when you start looking at the sliding fee rates that you put across the bottom of your scales in terms of where you're at, it is not tied to actual cost. Usually it's tied to being able to what they can afford to make it work. You can be able to implement multiple different discount schedule levels. You have to have at least 3 pay categories between 100 and 200% of poverty. Some centers have done, 4 or 5. I've even seen a center once that had 10 discount levels. I would never do that. If you felt like you felt the need to do that, you could. But you have to have a minimum of 3. And we'll see that in a second. And then you can always have multiple scales as long as it's based on the type of service related, such as one for medical, one from dental, one for behavioral health type thing, or basically based on how the service delivery method, which is more like basic dental versus restorative dental, things that would have additional costs and maybe a little more complicated. So here is an example of what a sliding fee scale can looks like. You can do it different ways. The most important part here is looking at the protected class that HRSA has is 100% of lower poverty. You cannot break down any lower than 100% of lower poverty. So that is always your first category. And that one is based, you sitting there looking at it and you could do a nominal charge. In this example, I put $20 for medical and $40 for dental because you could have different rates, like I said before, for that. And I have right here 3 different categories between 100 and 200% of poverty. And it has to graduate, the value has to graduate. So I've seen some examples sometimes where I see centers that put the same rates on different scales, different deals. That doesn't graduate it. So you have to have different rates for each of those different scales, and they need to be increasing. So here I did a flat rate on my example. And then there is no discount above 200% of poverty. So you have to have a discount between anything up to and including 200% of poverty, but after above 200, there is no discount. Now, in terms of implementing this, you have to make sure you have clear policies and procedures for determining eligibility. You need to be able to have it written that's easy for everyone to follow through the guidelines. So be sure to, when you're writing them, make sure that you read through it and make sure that it really meets what you're doing. Sometimes giving it to a second set of eyes that don't know the program and see if they can understand it afterwards is a great way to kind of make sure that those policies and procedures are actually following what you expect them to have. You need to have written documentation for patient eligibility. So you need to, for every patient who is eligible, you need to have provide documented support that through this and making sure that you keep track of that support for future audits. So things like your application, most centers have a written application in health centers that patients sign. So you want to make sure that they have that you keep that documentation in your records for review, as well as any income support that you may collect to be able to determine where they fall in the federal poverty guidelines. Usually the application also will include the number of people in the household, so you can kind of get the full picture of that. And I encourage you to include on there what level that you was assigned at that time. The frequency of your income verification, that's set by in the policy. Usually it's set like once a year. That's usually the easiest and less burdensome for most centers. So you want to make sure that you have that in there and then reevaluate it at the end of that year. I encourage you to think about that and keep track of all those pieces, all right? And obviously staff training and responsibilities. All staff should know about the program. I mean, a lot of times I've been to centers where providers think that patients can't afford it, so then they try to undercode those charges, which is illegal. So you want to make sure that everyone on your staff knows that there's such a program and kind of the basics of it. But you really want to make sure that your front desk staff or your eligibility assistance people that are actually doing the application, the eligibility portion, really understands the program and understands and maintains that documentation. So in terms of the application itself, sliding fee discounts apply to all ranges of in-scope services. So you want to be able to, any services that you have in scope, which again is on Form 5A if you're familiar with that. So things like medical, dental, behavioral health, your pharmacies, all that stuff should have it, and you should ensure that patients are receiving a discount of those different pay categories, as well as, all your policies in terms of collecting and enforcing payment policies. These are making sure that everyone's treated fairly. Now, you just want to make sure that it's fair and that it does not become a barrier to receiving care. So you want to make sure that you're distinguishing between ability to pay and inability to pay. So you definitely don't want to deny someone care if they can't afford it. But you want to make sure that you're trying to collect that same fee as you would any other patient that may be coming in the door. Also, with the sliding fee discount program, you need to make sure that it really is focused on your uninsured and underinsured patients. They're the ones that are really going to benefit from the program. But you don't get to determine who's underinsured. You have to do that based on the federal poverty guidelines, like I outlined. So that's why I say you want to offer it to every patient that walks through the door. You never know who may fall into it that could qualify. Also, you want to be able to coordinate it with patients that have third-party insurances, Medicaid, and even Medicare at times, depending on what's going on there. You want to be able to coordinate care because often there's gaps in care. And you want to make sure that you want to be able to reduce any out-of-pocket expenses. So when you're coordinating that, of course, the first payer is always at this point is the insurance company. You're sliding just the amount that's the copay comes out of the pocket of the patient. In terms of compliance, I encourage you to do an internal review of your program as you go along, just to make sure that things are being done correctly and consistently with federal guidelines. Just maybe look through a couple of them, especially when you're starting out with a program or having new staff, making sure that they're doing it correctly. Documentation that HRSA is going to want to see when they come out and do their review. They're going to want to see that signed application that you had the patient complete. They're going to want to see any income support that you've provided or received for that, as well as what you determined as their scale based on the federal poverty guidelines. They're also going to want to see, obviously, your policy and your scale itself. So you want to make sure that you're keeping track of all those pieces. And then if there was anything that's found to be out of compliance, either by HRSA or if you're finding anything like that, then basically you're going to need to just develop a plan on how you're going to correct those issues and rectify the problem. So most of the things with sliding fee is as long as you understand the program when you get going, in terms of corrective action goes pretty easy, and it's just basically basic easy fixes to be able to fix those things. Now, special circumstances, I can't even talk, I'm sorry. Special considerations for contracted services. So on your Form 5A, you had, column 1, which was pretty obvious because your front desk staff are taking care of patients that are walking through the door. But you also need to make sure that your column 2 and column 3 providers that you may be sending your patients to are also covered under the sliding fee, all right? So for centers, for anyone that's usually a column 2 service, if they're not using your front desk to it, you need to be able to, I would say you would want to let that provider know that they qualify for the sliding fee. Actually, both of column 2 and column 3. Let them know that they qualify for the sliding fee so they could be able to make sure that they're providing also that discount. It's required that every one of your patients that you're seeing in services must be able to get that discount. So you want to make sure you qualify that. In terms of compliance, contracted providers are required to follow the same sliding fee standards as the health center has, but in some cases it can be a better deal. Many times hospitals, for example, will have their own financial aid program, which is great. It makes it really easy for them to agree to that because column 2 and column 3 providers really are the ones that have the harder time being able to provide that discount. But hospitals usually have their own financial aid program. And a lot of times those programs are a better deal than actually the same requirement because you have to meet the same requirements as HRSA. But if they're actually a better deal, that's even better. So a lot of times I've seen hospitals that have full discounts up to and including 200% of poverty when you can only do that for 100% of poverty. Oh, I missed that. I knew I'd forget a bunch of things earlier. We'll come back to that, I'm sure, later. I'll come back to it. My brain just kicked right back in. Contracts and MOU must have languages in there, basically saying that they're going to provide those types of discounts. There's lots of different ways you can do that. Usually, if they have their own program, it makes it really simple and easy. Otherwise, you're going to have to negotiate with them to figure out what they can do to be able to provide that same sort of discount program for your patients. In terms of best practices, you definitely do have to have clear communication for patients. Patients need to be able to know you have a discount program. The best way to do that, obviously, is to have signage. There are different ways you can do it, but the best way to really do it, I found, is to have a sign at the front desk with very simple language. I mean, you could do it different ways. A lot of people say different things, but I remember the first time I was sitting in a waiting room at a community health center, and the sign said, we offer a sliding fee discount. I had no idea what that meant. I understand what the word discount means. So I encourage people most of the time to have a sign that basically says, we offer a discount for patients that qualify. Please ask at the front desk. Really simple and easy. You don't need to put a lot of words in there. You make it too complicated, they don't understand it. I also encourage people not to post the scale itself. I know some consultants say you should, but really that just is a lot of numbers, and most patients don't understand what that means. So I encourage you to, if you wanted to have that scale, obviously you should have that available, have it behind the front desk if a patient asks, but otherwise signage works great. In terms of reducing that financial burden, administrative burden on maintaining compliance, realize that when you're doing your evaluations and that sort of stuff, if you're giving them a year certification, you do the recertification. It's best to have it say on that, have that done on their anniversary date rather than at the beginning of the year. I've seen it done both ways. I think it creates a lot of extra work for the front desk people who have all of a sudden have, maybe 20 or 30 sliding fee patients coming in January 1st, say, for example, and now they've got to reevaluate them for the sliding fee versus doing them on their anniversary. And periodically review your sliding fee program. You need to make sure that it's not causing any financial barriers for patients. So with that in mind, you want to make sure that you're getting some patient input, as well as maybe from your staff. The best way to get some of that patient input is through survey questions. It's usually the easiest. You usually have a patient survey that goes out to patients, adding a question or two, making sure that does the cost of care today provided produce a barrier to care for you today? And a lot of times they answer truthfully. I know some people think that they don't, but they really do answer truthfully. Or you could do it through a focus group. In terms of compliance audits, as a reviewer, because I am a reviewer, like we mentioned earlier, I'm going to be looking at your compliance. I'm going to be looking closely to determine how did you determine your eligibility, the documentation you provided, as well as making sure that your policy has all the required federal requirements in it. Common findings that I have, there are lots of different things that I find wrong here. A lot of times some things are super easy to fix. Sometimes someone transposes a number on their scale and they didn't catch it. Those are things that's nice to have a second set of eyes to just double check those. Numbers get kind of confusing sometimes, and even for people that do numbers all the time like I do. So you want to make sure you have a second set of eyes on that. Other things include making sure that you're using gross income when you do your evaluations versus net income for patients, because people can have all sorts of different things withheld from their pay, but gross income really is the focus of what the federal poverty guidelines are set up as, and that's what you really should be using. And really the other parts are really just making sure they're evaluated correctly. So that's really the most common findings I'm finding anymore on it. I'm finding most health centers are really understanding this program more and more as time's gone on. In terms of preparing for HRSA operational site visit, the best thing to do is remember that when you get to pick those samples, and that's where I'm going to find a finding is going to be in those samples. You want to make sure someone reviews those samples before you upload them into the share file for us, because if you get to pick the samples, unlike a financial audit where the auditor may decide I'm going to look at sample 1, 2, 3, and 4 type thing. We're going to be looking at you pick which ones you're going to upload for us. So make sure that you look at it. Make sure that they are patients that in which they use the form correctly. They got applied to the correct citing fee amounts. Make sure that you updated the federal poverty guidelines. Like I said earlier, the federal poverty guidelines were updated in January. They're always effective the date that they're uploaded. So if you were to have a review the day after the site visit, it would be out of compliance because you weren't up to date. So most people aren't going to be able to upload it and correct it within one day, but something to think about if you were to have a visit between the point where they updated versus actually have it. So it's been updated. It's been out there now for a month. As a reviewer, I would expect that you would have the most current federal poverty guidelines on your scale. That's really the most important things that I would see in terms of those reviews. I definitely don't need to see in terms of your samples, picture ID or anything like that, because those type of things, I'm assuming you're asking for all patients. So I wouldn't bother putting any picture IDs in there or anything like that. So, and of course, you always redact the patient information. And when you do that, making sure that the family size is easy to identify. So sometimes, as you're redacting the patient information, some people hide out how many people are in the family, and you can't tell how many there are. So those are the big pieces there. And with that, all of this information that you need to be worrying about is right there in the, comes from the compliance manual. That's basically what we could call our Bible for the review. The Health Center Compliance Manual, it has all the regulations that HRSA has, or the Congress has created for the program. The site visit protocol is actually how HRSA has decided they're going to evaluate the program. Now, the compliance manual, going back there for a second, has not been updated since I think 2003, since they developed it. Maybe not 2003, 2013, it's not 3. And then the site visit protocol usually gets updated about every year or two. So I think right now we're on 2023, but I expect that we'll probably see a change in that this year. And of course, there's a link right there for the federal poverty guidelines. Like I said, it changes every year on January. And with that, I'll turn it back over to Kate to manage our questions.
Yeah, thank you so much, Chris. With that, we will open up the floor for questions. So if there anyone who's joined, if you have questions that we can address, please throw those in the chat and we will work through them. And then if you do have questions beyond these, or if you would like specific information regarding your situation, regarding your health center, we will be sharing contact information after this call so that you can reach out with any questions you might have. So anyway, while we give you a minute to think, I do have a question, Chris.
Okay.
You mentioned staff training and making sure that staff continue to share this with every patient. Can you share some best practices for making sure that staff are consistently communicating the sliding fee and its availability?
Yeah, the best way anyone that identifies a patient that mentions that they are having financial difficulty, you definitely want to send them to your patient navigator or your front desk person, whoever is evaluating them. And really, those are the people that should be doing it. Also, I encourage every new patient that comes into the health center to actually receive the sliding fee application that they can fill out. So that way they don't have to feel like they need that is a burden, that they need to ask for it. So they already know that what kind of a program it is. They'll be able to identify right away if they're willing to fill it out, if they qualify or not, and they understand how the program's going to work. Thank you, Kate.
Awesome. Another question that comes up is, let's see, excuse me. What are the most common mistakes that you see health centers make when they're first implementing a new program?
The most common mistakes I see a lot of times goes back to understanding the program and how it works. Making sure that they 100% of lower poverty is receiving no more than a nominal fee. You can give them a full discount, but knowing that's a protected class is what I call it at HRSA, that they were worried about. So anyone 100% of lower poverty is right there. And then making sure that no one above 200% receives a discount. You could give them a discount through other programs if you have other programs, but through HRSA, you cannot give them a discount. So you want to make sure that that's not included in your sliding fee. And then making sure that those three are in the middle.
Another important concern is often stigma. Are there ways that you can work with staff specifically to reduce any feelings of stigma that a patient may have when they do apply?
Yes, is understanding that understand the front desk or whoever, and like I say that because I don't know who's evaluating them, is making sure that everyone feels comfortable with it and understanding that HRSA gives this program the ability to have this discount opportunity out there, is just kind of giving them a little bit of a private space sometimes to be able to talk about it. Most of the time, most front desk places now, as long as you have you're a little bit off to the side, you maybe have a glass that you're talking, kind of blocking some of that talk and conversation. But definitely giving everybody that application so they don't feel like they have to ask for it. Always asking whenever a patient checks in, has your financial income changed? So they know that they can always reapply or apply at a later time as well. So they can always feel like they feel comfortable that they are being offered that without them having to ask for it.
Well, that's a very good point. Well, we did start a couple minutes behind the hour, so I have one more question, and then we'll go ahead and wrap up. What's the best way to evaluate effectiveness over time?
Yeah, that's a great question. A lot of health centers struggle with this part. The best way I think, to look at how to evaluate the program over time is looking at your annual UDS report and looking at to see how many patients fall into each of these different categories that you have. and then seeing how many visits that each one of those, the patients have in that section, and coming up with an average. So, for example, if your health center is seeing an average overall of, say, 3.5 visits per patient, your sliding fee patients are probably going to be pretty close to that number, if not maybe even a little higher, because usually your sliding fee patients are the sicker patients because they've delayed care too long before they've started seeking help. But if you see that you have patients that only come in once, then that tells me as a reviewer or even you that that maybe that fee is too much of a barrier, and then they need to be able to go back and then analyze why patients are only coming in once to be seeing you. I know I've seen health centers where they say, well, we have a lot of homeless patients, and that those are a little harder and a little more challenging to come into the health center. But with that in mind, most of the time they're not always transient. They're relatively close to the health center. They usually stay pretty close. And if they're treated right and they have the right, that's not a barrier to care for them to come in, they're liable to come in 2 or 3 times at least. So you want to make sure that overall that number is about the same as the overall. It won't be exactly the same, but kind of something to tell you to dig in a little deeper. Okay.
Thank you so much for that. And thanks to everyone who's on this call. We really appreciate you joining, and we hope this has been helpful as an intro. If you do have other questions we weren't able to answer, we'll be sending a follow-up email with contact information both for Chris and for Elizabeth Burrows. And we do welcome you to reach out with any questions specific to your organization. If you did gain insights or if you learned something new, we do welcome you to share this with colleagues or with other connections who might find it helpful. And looking ahead, in March, we'll be hosting another webinar on the chronic care management model, which we invite you to sign up for on the events page of our website at burrowsconsulting.net. And again, we appreciate you joining. Thank you so much. And keep an eye on our website for more webinars in 2025.